Hello, my name's Florence. Welcome to the theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter, anyone else that's interested, the theobspod is for you. Episode 34, Vaginal Examinations. Well, that is a strange title for a podcast episode, isn't it? Why have I chosen to talk about vaginal examinations? Recently, there's been quite a bit of chat on Twitter about vaginal examinations, or VEs, as we call them. This is because some hospitals are restricting access to birthing partners coming into hospital, into the labour room, because of COVID. And this is resulting in women being asked to have a vaginal examination and being told that only when she reaches a certain level of dilatation, the neck of the womb opening, that she is allowed her birthing partner. I'm glad to say that this is certainly not the case in my hospital. In my hospital, we have continued to welcome birthing partners throughout the pandemic. We firmly believe that it's very important for a woman in labour to be supported by someone she knows and she has chosen, in addition to the midwifery and medical staff. But seeing this conversation on Twitter and ending up being discussed on national radio, on BBC Radio 2, it got me thinking more generally about the topic of vaginal examinations, and I thought it deserved an episode. So today I'm going to talk a bit about why do we do vaginal examinations, what are we hoping to achieve with vaginal examinations, and what is the evidence that vaginal examinations in labour are useful, and also importantly, is there any downside? By complete coincidence, as this conversation was going on to and fro on Twitter about the value of vaginal examinations in labour, I saw a woman in clinic. She'd had several babies before, and yet when I said I needed to examine her, she said to me, "I know that this should be easy for me. I've had babies before. I don't want to sound stupid, but I've actually never had an internal examination." Why is that so unusual? If you think about a vaginal examination, it's a very invasive, intimate examination. As a professional working in maternity or in gynecology, this is part and parcel of our everyday life. We frequently meet women and almost a few seconds later ask her to strip off so that we can examine her. We see this as routine. We see this as part of our normal daily practice. And we can lose sight of the fact that this can be extremely difficult for a woman, particularly those women that have had a history of abuse or have religious objections. But it can be difficult for all women. For medico-legal reasons, we're encouraged to have a chaperone, especially my male colleagues. This can be supportive to the woman as well as supportive to us, the professional, making us and her feel protected as we undertake a very intimate examination. But equally, it can, I think, sometimes appear voyeuristic. Not only are we going to examine you, but we're going to have someone watching. I wonder where vaginal examinations have come from. Is some of it medicalisation? As a medical student, I was taught that a rectal examination was a routine part of an abdominal examination. Logically, this made sense. In an era when imaging is difficult, to examine every area that might yield information seems sensible. A rectal examination can tell you about the prostate gland. Is it enlarged? What's its consistency in a man? And can exclude rectal cancer, hemorrhoids, or other pathologies. As medical students, we found it embarrassing. We found it difficult to gain consent and ask permission for such a difficult internal examination that felt quite invasive. But we were taught that no abdominal examination was complete without this. This isn't the case anymore. It's rare for me to do. I was about to say it's rare for me to do a rectal examination, but that's not actually true. But that might be a whole different topic. That might have to be a subject for a completely different podcast about stitching and examinations before and after stitching. In the same way we learnt about rectal examinations as part of an abdominal exam, vaginal examinations in gynecology can tell you an enormous amount. They can tell you about the size and the position of the uterus, the womb, and whether or not there are any masses either side that could indicate an ovarian cyst, or whether there's tenderness that might indicate endometriosis or scar tissue from pelvic inflammatory disease. It could also tell us if the pelvic organs were mobile, as they should be, or whether they were fixed, a so-called frozen pelvis with everything stuck down, again an indicator of a pathological process and something being wrong. So examinations in gynecology can tell you a lot. Again, this was much more important when the availability of scanning and the images from scanning were more limited. But they still give you useful information. Let's now turn to pregnancy. Antenatally, what could be the purpose of a vaginal examination? It can be essential, can be really important in the diagnosis of preterm birth, for example. Is the cervix, the neck of the womb, starting to open up prematurely? Is it shortening and opening at a point when action needs to be taken to ensure the best outcome for the baby? It can be important if a woman is admitted with bleeding. We need to examine her cervix and consider whether the bleeding is coming from the pregnancy or the cervix itself. And it can also be important when we're considering induction of labour. We routinely use something called a Bishop's score from a vaginal examination to give us good information as to the likely chance of success with induction and also what that induction process might involve. A Bishop's score is far more than cervical dilatation alone. It's about the position of the cervix, consistency, length, dilatation, and the position of the baby's head. I'm going to deal with induction in much more detail in a forthcoming episode, so I won't go into more detail here. But in the antenatal period, let's say, vaginal examination can be useful. Let's turn now to examinations in labour, and once again I've gone back to my 1930s book of obstetrics. Interestingly, it says, Repeated vaginal examinations are to be condemned as they expose the patient to septic infection. Nevertheless, a single examination carried out with scrupulous cleanliness often yields valuable information without much risk of serious infection being incurred. Wow, that's some sentence. In those days, an examination would perhaps reveal a contracted pelvis from rickets, a malposition such as a face or brow presentation, or a malpresentation such as breech. It was undertaken ideally with the membranes intact, so the waters not having broken, and only when there was considerable delay so that the practitioner could understand what manoeuvres, either internal or external, might be required to correct things for the benefit of the mother and baby and minimise the risk to them when there was considerable delay. Let's remember, there wasn't the easy recourse to caesarean that there is now. How did we progress from perhaps a single examination being helpful and repeated vaginal examinations being condemned to the situation in which we find ourselves now, where we regularly examine women? What does national guidance say? Interestingly, I looked it up. So, I've put some links to the guidance in the programme notes. It says, if there's uncertainty about whether the woman is in established labour, a vaginal examination may be helpful after a period of assessment, but is not always necessary. If a woman appears to be in established labour, offer a vaginal examination. It goes on to say, when conducting a vaginal examination, be sure that the examination is necessary and will add important information to the decision-making process. Recognise that vaginal examination can be very distressing for a woman, especially if she's already in pain, highly anxious, and in an unfamiliar environment. Explain the reason for the examination and what will be involved. Ensure the woman's informed consent, privacy, dignity, and comfort. Explain sensitively the findings of the examination and any impact on the birth plan to the woman and her birth companions. As I read that guidance for this episode, I must admit I felt a little sheepish. I'm on a labour ward, week in, week out. We are regularly examining women. And I'm not sure I can say hand on heart that every single examination I do, I think through every single one of those steps. That's not to say I'm an uncaring doctor or that I don't recognise a vaginal examination can be distressing. I've got used to vaginal examinations as a routine. It's something I don't think about in a great deal of detail. I do, in that I want to know what the information is that I'm getting from that examination. And I do in terms of timing, because I will often say to the midwives, actually, why don't we give her longer? There's not much point doing an examination at the moment. It's not going to affect our decision making. Or it's too early, she hasn't been contracting enough. But I'm not sure hand on heart I can say that I follow all those recommendations all the time. And if I'm not doing that when I'm quite a person-centred obstetrician, or like to think I am, then what about people that are less conscious of the impact they're having on a woman's experience? Is this partly why we see women who appear to have had what we as professionals consider to be quite a straightforward normal birth sometimes return to us with birth trauma, saying they found the birth very traumatic? What are we inadvertently inflicting on these women? Informed consent, privacy, dignity and comfort. Surely those are a given. But we mustn't forget the issue of power. When we're undertaking a vaginal examination, that gives us power. We're telling women what their bodies are doing. The current example in COVID is an extreme example, but it's a manifestation of using vaginal examinations as power over women. We, by examining you, are going to tell you what your body is or isn't doing. Perhaps this might be telling women they're not in labour. You're only 2 centimetres. And this is how we end up with radically different versions of events. If asked how long was your labour, a woman might recount 48 hours. And a midwife or doctor might say 10 hours about the exactly same experience. We might explain to a woman, you weren't in labour that long. The first bit was early labour or latent phase. Once labour was properly established, it was only 10 hours. At the other end of the spectrum, we might tell women, no, you're not ready to push. There's still a bit of cervix left. And I recently read a very interesting blog about anterior lip. The article's entitled, The Anterior Cervical Lip, How to Ruin a Perfectly Good Birth. And again, I've put a link in the programme notes. We can inadvertently use vaginal examinations to also pass judgment on progress. I've had women ask me, how many centimetres do you expect me to be? They know there's a clock ticking against how their body's behaving. They know they need to get to the magic 10 centimetres to be able to birth their babies. And let's not forget, vaginal examination isn't an exact science. What are we actually doing? We're using usually 2 fingers, index and middle finger, of our dominant hand, inserted into the vagina to assess the cervix, the position of the baby's head, where the baby's head is in the pelvis. And examinations between different professionals can be very different, which can be confusing to a woman. Ideally, any vaginal examinations should be done by the same person. The same person can feel, is there a change? Is there a difference? As one person's 6 centimetres might be another person's 8. After all, we're not using a ruler. We can't be exact about the number of centimetres. And our fingers aren't all the same size either. For example, for me, I know pretty much if I can get 1 finger through the cervix, that woman is 1 centimetre. If I can get 2 through, that's 3 centimetres. 5 and 6 centimetres is a little bit more difficult to estimate. Sometimes you'll see midwifery students and medical students carry around little discs which show gradually increasing stages of dilatation so they can check their fingers against them after they've done examinations. Once you get to about 8 centimetres, what you're actually thinking about is not how dilated is the cervix, but how much of the cervix is remaining. Is it pulled back against the baby's head, what we call well applied? If there's a rim of 2 centimetres all around, then she's probably 8. If there's a small rim all the way around, we might call it 9. But it's extremely subjective. So let's not pretend that vaginal examinations are scientific. So why did regular vaginal examinations creep in? And when did they creep in? When I look at it, there's quite a bit of literature that seems to be based around the 1970s. And I wonder if the regular use of vaginal examinations came in with a move to hospital birth, or with the advent of so-called active management, where doctors were using syntocinon, synthetic oxytocin hormone, to try and speed up labour. If our guidance says regular examinations 4 hourly or in response to a woman's wishes, what does it say for women in less economic developed countries? WHO does recommend 4 hourly vaginal examinations to assess the first stage of labour, despite a note of caution about the significant impact of infection, maternal and neonatal, on outcomes. I'm puzzled by this too. These days we're worried about sepsis in labour, chorioamnionitis, infection in the membranes and waters around the baby. This can make both mother and baby ill. And this tends to occur if labour's been going on for a long time or the waters have been broken for a long time. But I can't help wonder whether this is also related to the number of vaginal examinations. When I originally trained, before doing a vaginal examination with sterile gloves, we used to wash the woman with antiseptic solution. Then we moved to using water, as there was no evidence antiseptic solution was beneficial. Now it seems as if we've moved to using nothing at all. If vaginal examinations are a bad thing, why do we do them? Why might we want to do them? Sometimes we'll do them because a woman's asking for pain relief. It can be that a woman's asking for pain relief and epidural just as she's reaching a transition point in her labour between first and second stage, and actually her babies are out to arrive and an epidural's not that helpful. We can also do one if a woman's thinking about pethidine, as ideally we don't want to give this just before a baby's born because it has an effect on the baby. We might do one because labour seems to be going more slowly than we expected. Or we might do one if there's a change in the baby's heartbeat that we're concerned about and we want to know how soon birth might be expected so that we know what the best course of action is. We might do one to exclude a specific problem, such as a cord prolapse where the cord comes down into the vagina. Having talked quite a lot about vaginal examinations, what are the alternatives? How else do we know if a woman's in labour? Well, if you work in maternity, you know when a woman's in labour. You can tell by her breathing, her behaviour, how she is, how she's moving around, how frequent the contractions are, how long the contractions are. We can tell quite a lot. Any maternity worker can tell you, if you work on a labour ward, that even from outside the door, without even seeing a woman, you can tell when someone's about to birth their baby from the sound alone. You can tell when someone's fully dilated and they're pushing, sometimes called involuntary pushing, because the woman is going with the urges of her body. So we can tell that. We don't need a vaginal examination to help us. There are visible signs as well, such as vulval gaping and anal dilatation, that can tell us a woman is fully dilated. And I've attached in the programme notes a visual poster that someone made as a result of the conversation that was going on Twitter, of the ways you can tell a woman's progressing in labour without a vaginal examination. Changes in the baby's heartbeat can also tell us what's happening. The baby's head is descending. You can get decelerations due to head compression, which are completely normal. So often I can look at a baby's heartbeat trace on a central monitor and say, that woman must be fully. She must be going into the second stage. So where does this all leave us? With today's zesty bit, I think I want to go back a little bit to what I said last week. Before you undertake a vaginal examination as a professional, think, What am I hoping to achieve by this specific vaginal examination? Will it change the plan for this woman or this baby? Try and keep them to a minimum and be meticulous about infection. Try and follow that national NICE guidance. Recognise that the examination can be distressing for a woman. Explain the reason for it and what will be involved. Ensure that the woman's consented, that she's got privacy, dignity and comfort, and explain the findings. It's her body, not yours. Yes, in medicalised labour, perhaps induction, or perhaps birth after a previous caesarean, vaginal examinations are very useful. But let's try and keep them to a minimum and keep thinking about them as a very specific examination that needs a lot of respect and a lot of thought, not just day-to-day bread and butter. If you're a pregnant woman listening to this podcast, then understand that vaginal examinations are being offered and are optional. And if you want to read a bit more about it, I've included the NHS information and the NICE guidance information for women about vaginal examinations, so you can understand what's relevant to you. And it can help you decide whether or not you want to have them. And if you do want to have them, how often are they likely to be needed or for what reasons? I hope you found this episode interesting. I could say a lot more, and I've enclosed some reading that you may be interested in the programme notes, including the Cochrane Review on vaginal examinations and the information on the scope of the Cochrane Review, what things they were looking at, because that gives more detail about other possible signs of progress of labour. I do hope you've enjoyed listening to this episode of the theobspod. Feel free to contact me on Twitter at FW Maternity or at theobspod to ask me questions, give me topics for future episodes, or let me know what you think. It's absolutely fantastic when you get in touch. I really enjoy reading your comments. As usual, I've tried to include in the programme notes some extra reading about this particular topic, both for professionals working in maternity care and for pregnant women using services. I'd like to reassure you that although I'm talking about my experiences working in maternity care, I take confidentiality very seriously and do not give any personal information about any of my patients. If you've enjoyed listening, I'd love you to recommend the theobspod to friends or colleagues, and please do leave me a review on whichever podcast directory you find my episodes. Many thanks for listening.